Welcome back to another scanning demonstration. I'm Brandon Winchester, the co-founder of BlockJocks.com, and for this scanning demonstration, I'm going to be showing you the basics of an infraclavicular block. The infraclavicular block, like the supraclavicular block that we have demonstrated more proximally, and like the axillary block that we'll demonstrate more distally, can be used effectively interchangeably for every major upper extremity surgery outside of shoulder surgery. So essentially anything just above the elbow and down will typically have the option of using an infraclavicular block. Now, one of the most common things that we get asked is how do you make a decision between a supraclavicular, an infraclavicular, and an axillary block? Well, the good news is that it leaves, in most situations, a lot of flexibility, knowing that you can use any of the three for all the major non-shoulder surgeries from about mid-humerus down. So typically the first deciding factor is which one are you most comfortable with, supraclavicular, infraclavicular, or axillary. We typically find in our practice that the infraclavicular is kind of our happy medium, is kind of our medium porridge, so to speak. We like this particular approach for just about all those surgeries as our first choice because it's a place where you can see all the cords, the lateral cord, posterior cord, and medial cord, all closely bound together, and therefore very little redirection is absolutely needed with your needle and with your injection in order to completely anesthetize the brachial plexus. So our general thought is that it's a relatively straightforward block, it's very effective, not a lot of needle redirection required, and it tends to be our preferred choice. Now let's compare it to the supraclavicular block initially. What is the absolute reason that you might want to use an infraclavicular block over a supraclavicular? The absolute reason is going to be comorbid pulmonary disease, namely because blocks above the clavicle, both interscalene and supraclavicular, can cause a phrenic block paresis, a phrenic paresis. And when you cause phrenic block, you cause hemiparesis of the diaphragm on the ipsilateral side, on the same side that you're blocking, and therefore you don't have the ability to breathe as deeply on that side versus on the opposite side, whereas the blocks below the clavicle don't have any incidence of phrenic block. I was able to search a case report once of a phrenic block secondary to an infraclavicular block. So it's obviously very rare below the clavicle, whereas with the supraclavicular block it can be upwards of 50 to 60% depending on the technique that's used, and of course with an interscalene it's often nearly 100% with traditional techniques. So that's the main reason you use the infraclavicular, or as we'll talk about later, the axillary, versus a supraclavicular block. Now, if you're placing a continuous catheter, one of the indications clinically for an infra versus a supraclavicular catheter would be that the surface in which you're inserting the catheter, the skin surface is the chest wall. The chest wall, as you know, is not mobile. It's a very fixed surface. So with arm movement, the chest wall stays very fixed, whereas with the supraclavicular insertion site, arm and shoulder movement could cause movement at the skin insertion site, and therefore, theoretically at least, may increase your potential for catheter dislodgement. So that's a secondary, more soft reason why you might choose an infraclavicular catheter in this case versus a supraclavicular catheter. The other reason is, although not extensively studied, that when compared head-to-head, at least in one major head-to-head study, the infraclavicular had slightly better pain scores, slightly better narcotic consumption versus the supraclavicular catheter when comparing them head-to-head. So for catheters, there's a couple of reasons why you might consider infra versus supra. For single-shot blocks, if all else is equal, they can be used effectively interchangeably. But when you have a comorbid disease, a comorbid pulmonary diseased patient, dropping that phrenic nerve, blocking that phrenic nerve is not a wise idea, and running the risk of that above the clavicle is worth avoiding. If all else is equal, it's worth going ahead and trying an infraclavicular block. So versus an axillary block on the other end of the spectrum, probably the main advantage of an infraclavicular block is sort of what I was saying before, that it doesn't involve a lot of needle redirection. The lateral cord, posterior cord, and medial cord are all very closely bound together, and therefore there's not a lot of needle redirection. In fact, good data has demonstrated that if you put the needle just deep to the axillary artery, right next to the posterior cord, and inject your entire bolus without any needle redirection, that you have equal success rates and even equal onset time versus a multiple injection technique with either 2 or even 3 injection points. So that is in contrast to the axillary block, which involves a requirement for multiple needle redirections in order to get all 4 nerve territories, the musculocutaneous, the median, the ulnar, and the radial. And so the advantage there of the infraclavicular is less needle redirection. The other advantage versus an axillary block, if all else is equal, is that there's less vasculature, there's less veins hiding around the target nerves. I like to joke sometimes that an axillary nerve block is like a venous moat around a neural castle, because in the axillary plexus, especially in certain patients, you just have very big veins sort of all over the place, sometimes blocking your path in multiple directions. So sometimes it makes it a little more difficult and challenging to get the needle tip to all 4 of those target nerves with an axillary block. So for the reasons I mentioned, generally speaking in our practice, an infraclavicular block is the preferred choice. The downside, if there is to be one, is that generally speaking, the infraclavicular block tends to be a little deeper than the supraclavicular block. Of course, the axillary is the most superficial of all the 3. But supraclavicular blocks for any given patient, an infraclavicular block tends to be about 1 to 2 centimeters deeper than that same patient's supraclavicular fossa. So you may have a little bit of a steeper needle angle of insertion, and you may have, as a result, a little bit more difficulty seeing your needle. And we'll talk about some of the steps in order to offset that potential difficulty in just a moment. Now, the additional thing that I wanted to mention about the supra versus infra is more of an advantage of the infraclavicular, and that is that if you look at the anatomy of the supraclavicular block, your needle insertion from lateral to medial, for posterior to anterior, is essentially inserting directly in the direction of both the subclavian artery as well as the first rib and the pleura. So if you're not especially adept at excellent needle tip finding as you're doing the nerve block, I think that you're more at risk with the supraclavicular block of inadvertently puncturing the pleura and causing a pneumothorax versus an infraclavicular block. Supra, I think, because of the nature of the technique and because the needle's going at the lung, has a more potential, at least, to cause pneumothorax versus an infraclavicular block. When is that important? If you're a person who's doing this block for the first time, or if you're a fairly novice ultrasound user, using an infraclavicular block in the technique that I'll show you is probably going to lessen the likelihood of accidental puncture of the lung and subsequent pneumothorax. So that's something to consider. On the flip side, because supraclavicular blocks are more superficial, it may be easier to find your needle tip, and it may be easier to stay outside of the lung. And so it is a relatively easy block, as I usually say. Supraclavicular is an easy block with a much higher risk profile than an infraclavicular block. So again, all those points being considered, to make a short story long, as they say, I think that infraclavicular block is kind of a nice happy medium between the 3, between supraclavicular, infraclavicular, and axillary. Transducer, which one to use? Always an easy discussion, because almost every time we do a nerve block, we use a wide, linear, high-frequency transducer. So infraclavicular block is no exception. Now, traditionally, dating back to when I was training in residency, as ultrasound use for infraclavicular blocks was becoming more and more prominent, before we started changing the arm position, if we were used to using our arm position at the neutral position, like with a supraclavicular block, it used to be advocated that we would use a narrow, curvilinear, medium to low frequency ultrasound probe, because the clavicle would obstruct the placement of the probe and make it more difficult to insert your needle with a wide footprint probe. For the reasons that we'll talk about in a moment, that narrow footprint probe is no longer needed, provided that you reposition the arm like we'll talk about. So wide, high frequency, linear transducer probe for this, and just about every nerve block that we do, is the preferred probe choice. Now, where do we start usually in terms of depth and gain? Usually it's about anywhere from 4 to 5 centimeters is your typical starting point for depth. If it's a skinny patient, you may go down to 3.3 or so, or 3 centimeters in depth. If it's a large patient, you may go up as deep as 6 centimeters in depth. Just remember that with a linear transducer, you're going to start degrading your image pretty significantly once you get to about the 4.5 centimeter depth marking, and above, deeper than 6. Unfortunately, you have to switch to a low-frequency probe in order to reasonably visualize the tissues that are that much deeper. So if you have a patient like that, a really large patient where it's a deep insertion site, if it's a single-shot nerve block, I would consider an axillary block as a reasonable alternative to that very deep infraclavicular block in a circumstance like that. So as far as the probe placement, I'm going to go ahead and show you where we start in patient positioning and in probe placement. So you can see now our model has already assumed the Gudini clavicle position. Remember I mentioned that traditionally, when we were first using ultrasound for infraclavicular blocks, the arm was in the same neutral position that we discussed while supine for the placement of a supraclavicular block. What we've noticed is that this particular position makes it much more difficult to place your probe, but also to insert your needle farther from the probe because the clavicle obstructs the insertion. The clavicle essentially hugs the insertion site of where the needle is going to go in. Now, if you simply reposition the arm in what we call the Gudini clavicle position, where the arm is abducted, externally rotated, and approximately 90 or so degrees flexed at the elbow, that Gudini clavicle position is named as such because now the clavicle displaces substantially, essentially out of the way. So now the needle, with the probe position here in the deltopectoral groove, the needle is now going to be able to be inserted several centimeters away from the probe. As you can see here, this would be the required insertion proximity to the probe if the arm was at the side because of the clavicle being in the way. And with this approach, we can insert several centimeters farther away from the probe, thus allowing a much flatter angle of insertion. Inserting closer to the probe would involve a steeper angle of insertion. Inserting farther from the probe allows a much flatter angle of insertion, and as we've talked about before, the flatter the better in terms of optimal visualization of that needle. So there's three primary things that I overall like to mention in terms of optimal needle visualization with an infraclavicular block. The first I just mentioned, the arm position change to the Gudini clavicle position. The second I also mentioned, which is the allowance, the benefit of inserting, instead of right next to the probe, inserting a few centimeters posterior to the, inserting a few centimeters cranial to the probe, or in anatomic terms, lateral to the probe, and that allows that flatter angle of insertion. But there's a third step that's important, especially with infraclavicular blocks, and that is the rocking of the probe. And what rocking of the probe allows you to do, when you rock the beam back towards the needle, the beam angle, incidence angle that meets the needle is going to be closer to perpendicular. On the flip side, if you rock away from the needle, it'll be farther from perpendicular, and therefore less reflection of the ultrasound waves is going to happen against that needle. So the third important step with an infraclavicular is to rock the probe back towards the needle, like that, as opposed to rocking away from the needle. Rock the needle back toward the probe back towards the needle so that the angle of incidence of that beam is closer to perpendicular with that rocked angle. Farther from perpendicular, rocking away, closer to perpendicular, rocking towards. So Gudini arm position change, needle inserted several centimeters from the probe, oftentimes 4 or 5 centimeters away, and a rocking back towards that needle. Now again, as I mentioned, your initial starting position here is going to be approximately the deltopectoral groove. You're going to have a rocking motion back towards the needle insertion site. And from that point, all you're doing in terms of probe adjustment, in terms of part maneuvers, or as we joked about earlier, part maneuvers with the 2 R's, is tilting laterally and tilting medially. And tilt is always aimed to try to make the target brighter. You're trying to improve the angle of incidence being closest to perpendicular to the target nerves, because we're looking at them in short axis, cross-sectional view. There's going to be an optimal tilt angle that is going to be the most reflective when you're doing this block. And so for this one, we're going to try to enhance our tilt just like we always do to try to get that brightest white view of the nerves. And as I'll show you in a moment, in this particular case, it's about neutral. It's about perpendicular to the skin where we see that optimal view. So now switching to the ultrasound screen, I want to point out some of the key structures in terms of anatomic landmarks. The first structure, the axillary artery, here in the middle of the screen, I wanted to focus on, because that is the first thing you always want to look for when you're doing this block. When you put your initial probe placement into the deltopectoral groove, all you're doing is sliding medially and sliding laterally in the parasagittal plane. Parasagittal is just a plane parallel to the sternum. Parasagittal plane sliding medially, sliding laterally, and trying to find that optimal view of that axillary artery. From that point, in terms of finding the best place in terms of lateral to medial sliding for your probe, what I typically do is I slide laterally until I see that curvilinear white in the bottom left of the screen here, which is lateral, towards the needle insertion. When you see that curvilinear white, it knows you know you've gone too laterally. That's the shoulder capsule that you're looking at. So I'll take my probe and I'll slide it medially along that same slide path until I find an area where I see bright white deep to that axillary artery. That bright white is going to be your posterior cord. So the axillary artery is the large pulsatile structure here in the middle of the screen. To its medial side, to its right side, is the axillary vein. Now, one of the things that you can do in order to optimally visualize, or at least confirm that you're looking at not only vessel, but artery versus vein, is to turn on color flow and move that color flow over, slide that color flow over both of those vessels. As you can see here, with the color Doppler, you can see a very pulsatile flow through the axillary artery on the left side, the lateral side, and a much less pulsatile, kind of jugular-like pulsation through the axillary vein. Now if I squeeze the upper arm on the medial side on 3, you may see a little venous pulse rush through the axillary vein there. 1, 2, 3. You saw a little bit of additional flow through the axillary vein there. That's just a confirmation. You don't usually do this routinely, but it's just a little way that you can utilize, if in doubt, color flow Doppler to identify vessels, and more specifically artery versus vein. So now that we've identified and confirmed axillary artery from axillary vein, we can again slide laterally till we see the shoulder capsule, that curvilinear white laterally, and slide the probe medially to the first location medially that we see hyperechoic bright white deep to that artery. In this area here, down here, is the posterior cord, and that's going to be our primary target. Again, the lateral cord is going to be at around the 10 o'clock position, and the medial cord is usually existing, it's the hardest to find, but usually existing somewhere right between the axillary vein and the axillary artery here, or it can vary all the way along this plane here from about 1 o'clock down to about 5 o'clock relative to that artery. A couple of the other important structural landmarks to look for: there's a couple of muscles that are of importance. The superficial of the two muscles here is the pectoralis major, separated with this muscle plane from the pectoralis minor, which is the muscle belly here, pec major, pec minor. And really, in terms of structural identification, that's the most important thing to identify. Pec major and minor, axillary artery and vein, and the various cords of the brachial plexus, lateral, posterior, and medial. Now, I often get asked, where's the pleura in this particular block? And it's not, since you're so lateral, it's nothing that you critically have to think about. We're in a very lateral position here, right around the deltopectoral groove. If you slide way medially, where you do maybe a traditional landmark-based infraclavicular block, you may start having to think about pneumothorax. But we're well lateral in this particular location, making it one of its benefits, well lateral to the pleura, and therefore, since we're already lateral to the pleura, and since our needle angle of insertion is essentially parallel, or if you slightly rotate your probe, slightly away from pleura as you're advancing your needle, I think that's one of the advantages of making it a lesser likelihood of pneumothorax if you had a wayward needle, if you were to lose your needle tip and inadvertently put it in deeper and farther in than you anticipated or intended. So going back to this basic anatomy, your needle insertion is going to target the 6 o'clock position, inserting from lateral to medial, which relative to the torso is head to toe, left to right on the screen, until you get to approximately that 6 o'clock position. Now, generally speaking, our goal is to get a U-shaped spread around that artery. And that U-shaped spread is going to encompass the lateral cord, the posterior cord, and the medial cord while doing this block. And as I mentioned earlier, you can put all of your local anesthesia into this insertion site, the 6 o'clock position relative to the artery, without needle redirection, and data still suggests that that is going to have an equal success rate to needle redirection. Generally speaking, we do redirect our needle and inject a few additional injection points to enhance the spread, which in my opinion also decreases the likelihood of a catastrophic intravascular injection. Because if you inject all your local anesthetic in one place and it turns out that you accidentally, inadvertently were intravascular, that's a large bolus of intravascular local anesthesia. If you inject some here, some here, and some here, inadvertently, if you're in the vessel at any one time, you're going to inject less local anesthesia with each particular injection, and your overall intravascular bolus should be less as well. So that's one safety reason in my rationale that I think a multiple injection technique makes sense. Furthermore, I think it just hedges your bets. It allows you to enhance the spread better than diffusion is capable of doing, and potentially, at least in my hands, increase my success rate to the nerve block that I'm doing. So going back to the insertion site of the needle, as you often see in the textbooks, people insert needles very close to ultrasound probes, thus making them insert at a very steep angle. People have even written in articles as recently as last year that one of the important things to remember about an infraclavicular block is that you should not expect to see your needle while doing an ultrasound-guided approach. I completely disagree with this statement. I think that if you simply do what I told you to do, Gudini arm position change, rock the probe back towards the needle, and insert the needle farther away, in this case about 4 or 5 centimeters away from the probe. You combine those three things, there's every reason in the world that you should be able to see your needle when doing this particular approach. So 3, 4, even 5 centimeters away from the probe, approximately here is your insertion site with a very flat angle of insertion. It will come in from left to right on the screen. When you get to about the 6 o'clock position, if you're doing a dual guidance technique, you're looking for nerve stimulation in addition to visualization of the needle tip deep to that artery. If you stimulate that posterior cord, the most common twitch that you're going to get is an extension twitch. An extension twitch is going to be extension of the elbow, extension of the wrist, or extension of the fingers. Those are the types of things that you're looking for with the posterior cord twitch. Now, as I mentioned a little bit earlier, you oftentimes get a medial cord location up here, but it often creeps down into that deeper territory here, a little deeper, deep to both artery and vein. When you have a medial cord there and your needle tip goes under the artery and touches that medial cord, what you'll oftentimes see is an intrinsic hand muscle twitch. An intrinsic hand muscle twitch would be more like this, at what the frequency settings are of your nerve stimulator. So, when combining an ultrasound with a nerve stimulator for a dual guidance approach, if your needle tip is anywhere from about that 6 to 5 o'clock position, you will vary between an extension type twitch, a radial type twitch, which indicates you're stimulating the posterior cord, or an intrinsic hand muscle twitch, which indicates that you're more likely stimulating the medial cord. Both of those twitches are very reasonable endpoints for your target injection. Now, if you're stimulating the lateral cord out here at the 9 or 10 o'clock position, you're going to get more of a biceps twitch. It's essentially like a musculocutaneous twitch. And the musculocutaneous twitch is going to be more of a biceps twitch. And that's indicating that you're stimulating the lateral cord. Now, traditionally, if you get a biceps twitch, it may indicate, if you're doing a landmark-based technique, that you're causing a stimulation of the musculocutaneous nerve, which is one of the two branches off the lateral cord, the musculocutaneous being the lateral component and the median being that medial component. Now, with ultrasound, you can tell with experience whether your musculocutaneous has separated from your median nerve. But with a landmark-based technique, you weren't able to establish that musculocutaneous was, in fact, right adjacent to the artery. So we were always taught traditionally not to accept a musculocutaneous biceps twitch, because although in most cases it indicated that you were stimulating the lateral cord, there were occasional cases where an early departure of the musculocutaneous component of the lateral cord had already happened, and therefore you may be stimulating the musculocutaneous out here, indicated by a biceps twitch, and if you injected all of your local anesthetic, then of course you're going to miss the remaining components of the brachial plexus over here. So with ultrasound, it's not so critical to avoid accepting a lateral cord biceps twitch, but with landmark-based techniques, we were always taught to avoid injecting when you get a biceps twitch, and instead look for a radial type twitch indicating posterior cord stimulation, or an intrinsic hand muscle type twitch indicating medial cord stimulation. Just some food for thought in terms of the classic technique versus the ultrasound guided technique. In the end, with ultrasound, twitches aside, like I said earlier, your end game, your goal, is to get local anesthetic spreading around that artery, that axillary artery, in a U-shaped pattern. Now, typically when we're doing a minor wrist surgery, we're going to place a single injection nerve block, an infraclavicular block, or an elbow surgery or forearm surgery. When you're doing a more involved surgery, we do a lot of major reconstructions of wrists and of thumbs. When you're doing a major reconstruction down in that distal upper extremity, then you're more inclined to benefit from a continuous catheter technique. Now, the catheter technique is not much different than the single injection technique. Same insertion site, a few centimeters away from the probe. It's really the difference of what you do at the completion of the injection that makes it an infraclavicular catheter technique versus a single injection, with the main difference being, as it is with every single versus catheter injection technique, the catheter is a 20 gauge needle with a 20 gauge catheter inserted through an 18 gauge needle, as opposed to the usual 21 or 22 gauge needle that you use for a single injection technique. Otherwise, the single injection part of the procedure is very similar for a catheter versus a single injection. For a catheter, what you're looking to do is, after getting that U-shaped spread with your primary injection through your needle, usually we'll thread our catheter in from lateral to medial, and our needle tip will reside just under and past, just medial to the deep border of the artery, and the catheter will thread about a centimeter past that and be left in this space deep and past the axillary artery, so that the local anesthesia, as it exits the catheter tip, is going to infuse just deep to the medial cord, leak back along the catheter, infuse just over the posterior cord, just superficial to it, and then leak back right past the lateral cord, and then ultimately out towards the skin, because local anesthetic leakage happens along the path of least resistance. In other words, from the tip of the catheter, local will leak all along the catheter, because the catheter effectively acts like a wick. It gives it a path of least resistance, allowing the local to spread back. So if you insert your catheter past the target, you can count on a lot of leakage back towards those cords, and therefore I think a greater degree of success and a better spread of your local anesthetic to the medial cord, the posterior cord, and the lateral cord. You never want to leave that catheter short of the lateral cord or short of the posterior cord, because a lot of that local is going to leak back away from the plexus, as opposed to a catheter tip that's past the plexus. All the local anesthetic leaks back along past all three cords, and therefore I think is going to enhance your ability to get local anesthetic spread to each of those three cord territories, and therefore better pain control from your continuous catheter. Once your catheter is in place, you should expect to have anywhere from 12 to 18 hours of analgesia from your initial primary block. For that reason, we don't usually start our nerve block pumps, either inpatient non-disposable pumps or outpatient disposable pumps. We don't usually start ours until the evening of the surgery. A lot of centers will just go ahead and start it immediately after the surgery is done. We feel like you're wasting a few hours of numbness that's already going to be there whether you start the pump or not, and therefore we extend the total duration of the pump longer by starting that pump at a later time, around evening time. Our primary bolus of local anesthetic with this block, and with just about any other block that we do, is a 0.5% bupivacaine solution, bolused plain. In another video we talked about the epi versus no epinephrine debate. In our particular case, we use no epinephrine for our primary block. We place the continuous catheter and run a pump infusion of a more dilute local anesthetic. In our case, it's 1/8% or 0.125% bupivacaine. In the case of most practices, people are using a dilute solution of ropivacaine, 0.2% ropivacaine. In my particular case, I run the pump at 8 cc's per hour. I feel like because those cords are a little bit more spread out versus perhaps, say, a femoral or an interscalene, I like to have a little higher rate of infusion. So I start my patients' pumps at 8 cc's per hour. I give them the opportunity to turn the pump down or turn it up, depending on their preference. If they're too numb, I give them the opportunity to turn it down 2 cc's at a time every hour. And if they're too numb, or if they're having breakthrough pain, I'll occasionally have them give themselves a poor man's bolus, is what I call it. Turn the pump all the way to 14 or up to the maximum, anywhere from 12 to 20, depending on the pump, for just an hour, sort of a top-off dose, and then turn it back down to 8 cc's per hour, which is my absolute cutoff for, or maybe 10 occasionally. 8 to 10 is the absolute cutoff when you're running a continuous infusion without decreasing the dose. But occasionally you can do a poor man's bolus. Also occasionally, if all else fails, and especially if the patient's relatively nearby, you'll occasionally need to do a bolus injection with a stronger concentration of local anesthetic, something like 0.25% bupivacaine or something like 0.25% or 0.375% ropivacaine with a patient coming in. Sometimes the dilute solution on post-op day 1 is not dense enough, not strong enough. However, most patients do great with an 8 cc per hour infusion of either 1/8% bupivacaine or 0.2% ropivacaine. Hope that was helpful. As always, if you have any questions, feel free to email me, and stay tuned for another head-to-toe scanning video to come.